The New Jersey Center for Tourette Syndrome and Associated Disorders, its directors and employees assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented. We do not endorse any recommendation or opinion made by any member or physician, nor do we advocate for any treatment. You are responsible for your own medical decisions. Now, I'm going to turn over the introduction of our speaker to Martha Butterfield, the webinar coordinator of NJCTS. Marty?
Kelly, thank you, and good evening, everyone. Welcome. It gives me great pleasure to welcome back Dr. Mark Mintz to our webinar programming. This is Dr. Mintz's second appearance in our Wednesday webinar series. He's previously presented in May of 2013 on medication management for treating Tourette syndrome. If you are interested in that topic, you can download it free on our website. Dr. Mintz received his MD from the University of Medicine and Dentistry, Robert Wood Johnson Medical School in New Jersey, and completed his pediatric residency at the Albert Einstein College of Medicine, Montefiore Medical Center in New York. He is triple board certified in child neurology, pediatrics, and neurodevelopmental disabilities. Dr. Mintz is on the adjunct faculty at Rutgers, New Jersey Medical School and a member of the medical staffs of Our Lady of Lourdes Medical Center, Camden, Wiseman Children's Rehabilitation Hospital in South Jersey, part of South Jersey Healthcare, and Bancroft. He is widely published and has been an invited lecturer at a number of national and international conferences. Dr. Mintz functions as the principal investigator on a variety of clinical drug trials and has been the protocol neurologist for several national pediatric AIDS clinical trials and has participated on an array of committees and task forces for the National Institutes of Health and the New Jersey Governor's Office. Additionally, Dr. Mintz has served in the National Health Service Corps of the United States Public Health Service and has volunteered for medical relief missions in Romania and Russia. He was named Healthcare Professional of the Year by Autism New Jersey in 2009 and is regularly recognized as a top doctor by various publications. Dr. Mintz, we are delighted to have you back, and without further introduction, I'll turn tonight's presentation over to you.
Okay, thank you. So to start this talk, just a basic principle on concussions. There's sometimes a disconnect between the concept of the brain and the head. And people tend to use their head sometimes in disregard of their brain, but remembering that the head is where the brain is contained. So it's not a really good idea to use the head as a defensive or offensive weapon because the brain is contained within there, and also to understand that the head is attached to the rest of the body, so the brain is not necessarily immune from injury when other parts of the body are involved in aspects of sports such as collisions. The other thing that often is forgotten is that the brain, when it is injured, needs time to heal. People fully understand when they hurt their knee or they hurt their ankle that if there is insufficient time to allow it to heal, there might be a re-injury of that knee or that ankle. And the brain is really the same way. We really need to give it enough time to heal and enough time to recover. And if we don't, number one, it'll be a little bit more susceptible to re-injury, and number two, you could have longer-term effects. And the other issue is when it comes to concussions, that these are a form of a traumatic brain injury. Concussion is not some separate entity that is apart from brain injury. It is part of brain injury. It may be considered on the mild end of the traumatic brain injury or TBI continuum, but sometimes the residual effects can be quite dramatic, and actually, in many cases, a very mild TBI, if you will, TBI standing for traumatic brain injury, can be turned into a more severe long-term chronic issue, where sometimes more moderate or severe TBIs can resolve without major problems. So just because it's considered a mild TBI doesn't really shouldn't put it out of the realm that it is a brain injury that needs to be dealt with. So when it comes to concussion, again, this is an injury of the brain, and you can't just put a Band-Aid on it. You need to really understand it, identify it, provide proper management and treatment so that there's good time for recovery. So what are the events that, especially in particular in sports, we'll get more in detail, but in general, what are the events that lead to concussions? These include various forms of sports, contact and non-contact. Some people have the idea that it takes a direct blow to the head to sustain a concussion, and that's not true. In fact, the main issue with concussion is really the velocity that the head is traveling, and then the abrupt change in that direction and extent of that velocity that can cause a concussion. And we'll look at some details of that. Then slips and falls often lead to concussions, as well as other forms of traumatic brain injury, motor vehicle accidents, assault, collision with others in a non-sporting event. Military issues. Traumatic brain injury in general, and including concussions under that general umbrella, have been a major issue with our returning veterans from some of our recent wars. And it's really bringing to light, along with sports, the aspect of brain injury as a very life-altering event. Unfortunately, in very young children and infants, you can have head injuries that are non-accidental, a result of forms of abuse. And in some cases, it could be accidental, unintentional dropping of an infant, for example, could lead to traumatic brain injury. And in some cases, it's not fully known. Again, these are traumatic brain injuries. So as far as sports and concussions, there are some sports where the outcome is really, or the goal is really to invoke a concussion on your opponent. So we really have to, I guess, revisit the rules of engagement in some of these sports. If we're, one of the main aspects of concussion we'll be talking about is prevention. And if the main goal of a sport is to render your opponent unconscious, by definition, unconsciousness after a traumatic event is a form of a traumatic brain injury. And again, these are equal opportunity sports these days. So we don't just have to focus on the male population, but also the female population when it comes to traumatic brain injury. And, again, people are very, careful with the rest of their body in terms of protecting it with all sorts of equipment, but often neglect one of the more important parts, which is the head, where the brain is contained. So this is a sport that can lead to brain injury, and actually horseback riding causes a lot of brain and spine injuries. So something to keep in mind. It doesn't always have to be a direct engagement type of sport. Hockey is a major form of concussions, but not really from the fighting that is so popularized in hockey, but it's really more the high velocity collisions that take place during the game. Here, I think it's more just an issue of dental. It's very hard to actually have a true boxing match when you have all that equipment on. Extreme sports are being popularized in the younger generations in particular, and have to be considered because they are leading to a lot of injuries. There may be some protective equipment involved, but it's usually not sufficient to fully protect. And it doesn't take a contact sport to sustain major head injuries. So we have to be aware of all different types of recreation and sporting events that can lead to injury of various types, including brain injury. And it doesn't even take participation in the sport to get injured, and spectators are at risk, particularly at events like this, motor events. And of course, the new use of the cell phone for selfie pictures. One has to be a little bit aware of what's going on behind you. So, traumatic brain injury from sports and recreation activities is a major health issue. Many visits to the emergency room and sometimes subsequent hospitalizations from those visits. And it's been increasing over time. I mean, part of that might be due to increasing recognition and identification of head injuries, but also it may just be a result of the violence that's inherent in a lot of the sports. In 2001, you can see here from this study, there was over 150,000 visits, emergency room visits per year, and that increased in 2009 to 248, or per 100,000 population, an increase of 62%. The highest rate was in teenage males. The activities that were associated with the greatest number of TBI-related emergency room visits included those listed here. Bicycling, despite the use of bicycle helmets, you could still have significant head injury falling from a bicycle, particularly if it's struck by a vehicle or going at high velocity. Football, playground activities, basketball, and soccer. So if one looked at all injury visits to an emergency room, TBI accounted for greater than 10%. In horseback riding, like I mentioned, is a major problem. Ice skating. Now golfing, you might not even consider a sport that you're going to get a head injury, but mostly from the golf course, people falling off the golf course or golf carts falling over. All-terrain vehicle riding, ATVs, and tobogganing and sledding. As you might suspect, under 10 years of age, it was mostly playground activities and bicycling that were the main culprits. In teenagers, in males, it was mostly football and bicycling, and in females, soccer was high up there, and again, mostly from collisions, either with another player or often I see individual with concussion in soccer from colliding with the goalposts that are not padded. Basketball and bicycling again. Concussions are becoming very popular in the media, if you will, particularly as many of you know from the recent National Football League lawsuits, a litigation settlement of $750 million that I think was recently struck down by a higher level court because it was insufficient to cover the amount of expense that would be incurred by the individuals that were the plaintiffs in the suit. And from that, there's been some change in rules of engagement for sports, particularly like in football. They're trying to reduce the amount of head-to-head contact. They're trying to commission production of updated helmets that might be more protective. But since concussion mechanism is not necessarily dependent upon the direct head-to-head contact, these helmets might not necessarily be protective. And in fact, I would say sometimes the helmet gives a little bit of comfort to an individual to use their head more often in the course of play. And probably by eliminating helmets in football, you might actually reduce the amount of concussions because then people might be a little bit more careful with what they do with their head. The design of the helmets is quite problematic to really fully protect the head because, as we'll see, the mechanisms are more dependent upon acceleration and deceleration rather than direct contact. Other professional sports where you hear a lot about concussions, hockey, you hear about a lot of retired hockey players suffering from post-concussion effects. Tremendous number of concussions that can occur in professional hockey. For many years, it was kept somewhat under the rug and under the radar as people tended to not want to profess that they had concussions because it was a sign of weakness. Boxing, like I mentioned, is a sport where there's an intention to cause brain injury. Basketball also can lead to concussion, and one has to keep you aware of that. Though it's considered a non-contact sport, obviously, as many know, there's a lot of contact that goes on and a lot of falls that occur. Now, after a primary head injury or brain injury in high school and collegiate athletes, the risk of a secondary injury and a tertiary injury go up. And as the other issue in the media that has been, as you probably are aware of, is retired, particularly professional athletes, mostly has been publicized from football, who have been committing suicide and have a long history of behavioral changes, much different than their baseline personalities, and some of them have donated their brains for further examination, and the autopsies have shown the phenomena of chronic traumatic encephalopathy. which is a post-traumatic change, and we'll talk about that in a moment. So what is concussion? It's an old term from the 14th century, meaning to shake violently. It's defined really as an alteration in brain function from some form of external force. It can lead to a loss of consciousness or a decreased level of consciousness, but it doesn't have to. And so loss of consciousness is not a necessary marker for concussion. There can be the presence of amnesia after the event, and the amnesia can be for events that occurred just prior to the concussion as well as things that occurred after. And there can be various combinations of this. There may be neurological abnormalities, dyspraxia, which is the inability to do planned activities or movements, so it would lead to poor coordination, for example. Vision changes, sometimes paralysis, that's quite unusual, balance changes, or sensory loss. In particular, there would be some form of alteration of the mental state. There might be a little bit of disorientation, confusion, or sometimes just a feeling of being dazed, or what used to be termed having your bell rung. The external forces that cause concussion, again, is more this rapid acceleration of the head, and the brain goes along with the head, of course, in three-dimensional space, and then all of a sudden an abrupt stop to that, so that there's a very rapid deceleration, and that will tend to then sometimes cause the brain to move in the opposite direction, and that causes this whiplash type of phenomena. Blast injuries, which is a big issue with our military forces. The concussion, if you will, or the force of the blast can cause a force wave that can cause concussion. And of course, just blunt force trauma, just a blunt force to the head can cause concussion, as well as other forms of brain injury. Now, I mentioned that concussion is felt to be a mild TBI, and the reason for that is that usually after concussion, if you did a CAT scan or a magnetic resonance imaging or a picture of the brain, if you will, there won't be any evidence of any structural damage. The loss of consciousness is not necessary for diagnosis, and if it does occur, it's usually very brief. Alteration of consciousness usually is very momentary, but though it can last up to 24 hours. Amnesia sometimes occurs after the event, but usually will recover quickly. The Glasgow-Coma scale, by definition, in a TBI has to be very high. The Glasgow-Coma scale is really a measure of coma, so it's not really applicable to concussion. But 15 is the maximum score you get on the coma scale. So 13 to 15 is usually somebody, very much engageable. But there's no single diagnostic feature when it comes to concussion. So there's no one test or no one type of intervention or assessment that you can do to say somebody has definitely had a concussion. It's usually a clinical concept. And concussions can evolve over time as well. So when somebody has a concussion, they'll have the list here of the various symptoms and signs. Symptom is something you can complain about. Signs are things that you can observe. So these are some of the more observable aspects. Somebody appearing to be dazed or stunned, confused. If they're in a sporting event, they forget the plays. They're not sure of what game they're in or what the score is or who they're playing. They'll be a little bit more clumsy and poor balance than usual. Again, this concept of losing consciousness, even briefly, any loss of consciousness is by definition would be a concussion in a sporting event. The retrograde amnesia, where they can't recall events prior to the hit, and the anterograde, where they can't recall events after the hit. More importantly, if there are unequal pupil sizes, that's a very ominous sign for significant brain injury. They might have a vacant stare. They might be very slow in responding to your verbal responses or questions or requests. Speech might be slurred. Disorientation to time, date, and place. Behavior and personality changes can occur, sometimes right immediately after a concussion, but that's usually more of a long-acting problem. Convergence insufficiency is the inability to take the eyes and move them for seeing close objects. That's usually more of a longer-term problem after concussion. So these are some of the observable signs. This shows an unequal pupil. On the left of your screen is a large pupil, and on the right is a smaller one. Anytime pupils are unequal, unless it's a pre-existing condition, is a very important sign for something going on in the brain, especially after a traumatic event. Now, there are reported complaints after concussion, as listed here. This was from a study of high school and college athletes, and these occurred within the first 72 hours of the injury. And you can see here that headache leads the list. A general feeling of being slowed down, difficulty concentrating, dizziness, fogginess, fatigue, blurry or double vision, sensitivity to light. Sometimes you'll also get sensitivity to noise, memory problems and balance problems. And on the right, there's some other types of symptoms that often you can get from concussion that include nausea, vomiting, ringing in the ears, emotional lability, irritability, inattentiveness, impulsivity, sleep issues, and depression or anxiety. And I throw this slide in here too because one has to remember whenever there is an event that involves a high velocity collision and there is a form of concussion or brain injury, the spinal cord could be involved as well, and you have to be very, very careful of, anytime there's a spinal cord or potential spinal cord injury in a sporting event, that individual has to be handled very carefully because you could worsen that spinal cord injury and damage the spinal cord even further. And some of the clinical signs for spinal cord injury include tenderness and pain around the neck or neck bruise that you could actually see, blood pressure changes, low heart rate, problems breathing, temperature changes, priapism, flaccidity overall, of course, any type of movement issues after a injury on the field of play. You have to be very, very concerned about a spinal cord injury and or a lack of a response to pain. So how do these traumatic brain injuries occur? Again, by definition, for a traumatic brain injury, there needs to be an external force. You could have brain injury from other mechanisms, like a stroke, for example. That's not necessarily from an external force. So traumatic brain injury, by definition, is an external force. It could be a direct impact, acceleration or deceleration, as mentioned, rotational forces, contra coup, which we'll look at in a moment, which means that the brain injury occurs 180 degrees opposite from where the force is coming from, and penetrating injuries. Penetrating injury wouldn't be a concussion, that would be more of a traumatic brain injury. The results of these various external forces include fractures of the skull, contusions, or if you will, bruising of the brain, bleeding into the brain or hemorrhage or around the brain, swelling of the brain, what's called diffuse axonal injury, which the connecting fibers of the brain, the axons, which is sort of the cabling network of the brain, they get stretched a little bit and lose function, and therefore the communication in the brain networks aren't functioning as well. And then the metabolic cascade, which is something that's we're becoming increasingly aware of in the last 5 to 10 years as probably one of the major propagators of the brain dysfunction that occurs after concussion. So it's not necessarily a structural problem or a hemorrhage problem, but actually changes in the metabolic function of the brain cells. So when it comes to non-penetrating injuries, this rapid acceleration and deceleration of the brain is very important. Rotational forces, which could cause twisting of the brain and cause injury, particularly to deeper structures in the brain. And pressure waves, I mentioned, like after blast injury, can cause concussive type of injury, particularly also to deeper parts of the brain through various mechanisms. Now, the brain is protected by our skull, but that protection also can cause injury in certain situations when there is a very large acceleration or deceleration force. This is the internal side of the skull, this is the inside of the skull on the bottom, and you can see there's a lot of sharp edges to the skull. And the brain, the bottom of the brain is here, and that sits within the bottom part of the skull. So you can see that there's a lot of, if the brain were to move very rapidly front to back or side to side or twist, it could hit some of these areas sharp areas of the brain like here. And that could cause direct injury to the structural injury to the brain. So we'll take a look at what this means a little bit in terms of the forces of the brain. So this is from the side, and in the event of a straight-on hit, you can see how the brain moves forward and then back. And then from the side, it can twist and turn one way to the other. So as the head moves, the brain also moves as well for safety purposes. But sometimes when those forces exceed what the brain can handle, those stretching forces can cause significant injury. And you could also see, by the way, where the brain sometimes will start on one side. You could have a force directly to the front of the brain, but as the head moves forward, the brain hasn't fully caught up to the speed of the head, and the back of the brain, or the opposite side, can then hit the inside of the skull, and that could cause injury by itself, or what they call a contre-coup injury. So after an impact, the brain dysfunction can start sometimes seconds to minutes after the event, but sometimes there could be some delay, and that's due to the pathophysiology of this whole process. So in the first minutes to hours after an impact, there are various neurotransmitters that are either disrupted or released that could cause excitement to certain of the brain cells and lead to dysfunction. Inflammation tends to set in anywhere from hours to days after the event. And in severe events, after a traumatic brain injury, there can be apoptosis, which is actual death of neurons, which are the main brain cells, the cells of the brain that you use for thinking and memory and everything else. And that's, of course, a problem, and that occurs in things like chronic traumatic encephalopathy and some of the other long-term late effects of severe and repetitive traumatic brain injuries. I mentioned diffuse axonal injury. It occurs in the hemisphere of the brain. You have a right and a left hemisphere. And the type of diffuse axonal injury can be sometimes related to the angle of the force. And the sudden lateral movements can cause more in the way of diffuse axonal injury. Now, I did mention the biochemical cascade. And again, this is something that occurs. There's various features of the biochemical cascade. It's not all the same in every single individual. But after a traumatic brain injury, including concussion, I mentioned there can be inflammation. There can be changes in the way the brain communicates with itself in terms of these things called neurotransmitters, or little chemical packets that can help one brain cell communicate to another. And I'll show you some illustrative examples of that. Sometimes there are these things called free radicals that are formed, and they can cause significant damage. There are ways that the brain works in which various types of ions, such as calcium, sodium, and potassium, go in and out of the brain cells and cause activation or inhibition of different aspects of the brain. And after concussion, these ion channels, if you will, don't work as well. They can become leaky or not work at all, and that could lead to significant disruption of brain function. This could also then cause low oxygen to various parts of the brain when a lot of the aspects of brain metabolism are not working well. Sometimes after a traumatic brain injury of various types, seizures can occur, and it can even lead to epilepsy, which are recurrent unprovoked seizure events. Seizures themselves can sometimes be damaging to the brain. So that could be an issue. Sometimes the vascular flow, or the blood flow within the brain, is disrupted as blood flow in the brain is a regulated phenomenon. Various blood vessels will open and close depending on the needs of the brain. After concussion or after traumatic brain injury, this regulation is impaired, and therefore you could get abnormal blood flow to different parts of the brain, or insufficient blood flow to different parts of the brain. And then I also talked about this concept of apoptosis, which is where brain cells might die off after traumatic brain injury many days, months, even years after the event. Now, in some cases, this is a CAT scan showing after an event an epidural hematoma, or blood outside the brain, but abutting the brain, and you can see how it forms this sort of shape here. And this is actually can then push on the brain, and you can see here this black area is fluid, and there should be the same thing over here. So this part of the brain is being pushed over, and the brain's being compressed. And epidurals, hematomas, are a neurologic emergency and need to be addressed right away. This is what it looks like in the person, the top of the skull being cut away, and you see the large epidural hematoma. This is the covering of the brain called the dura, so it's actually outside it, or epidural. It's outside the dura, so it's not actually in the brain, but it's a little bit outside the brain, but actually more dangerous than a lot of bleeds that occur in the brain, because that extreme pressure can start pushing on the brain and actually pushes the brain all the way down and could lead to a life-threatening event. This is a subdural hematoma. That's over here, and this is below the dura, that part of the brain I just showed you. So when you take back that dura, then you see the brain a little bit more glistening over here, and you can see this dark area is the blood on top of the brain. It's below the dura, or what they call a subdural. Usually the epidural is more arterial, the subdural is usually more venous. So a venous bleed doesn't accumulate as rapidly, so a slower bleed sometimes can allow more time for the brain to accommodate, and also the subdural can spread out a little bit more. But the subdural can be life-threatening and very dangerous as well, but sometimes it can be very chronic and cause problems, but not necessarily cause an acute demise. Cerebral edema is brain swelling. This usually peaks at 24 to 72 hours after an event that causes brain injury. It's due to many different problems, but the main issue is compression of tissue, just like the bleeds. And when you have compression of tissue, you have disruption of blood flow to parts of the brain, and it leads just to a cascade of events that leads to significant problems with the brain, and sometimes a risk of herniation. And herniations, again, when either from a bleed or from brain swelling, there's pressure on top of the brain. This is the bottom of the brain. And you can see here, this is the temporal lobes. And this temporal lobe is actually pushing on this part, which is the brain stem, which is a very vital structure of the brain that controls a lot of our automatic functions, like breathing and heart rate. And this causes a pressure on the brain stem and can cut off the function of the brain stem and therefore lead to death. So herniation is a very important event that could occur after brain injury from bleeding or swelling. There could also be bleeding in another part of the brain space, not in the brain, but around the brain, called the subarachnoid space, and that could lead to brain swelling as well. It could be important. Sometimes it could just lead to a very bad headache, and sometimes it could lead to a life-threatening event. Stroke can occur after a traumatic brain injury, including the type of acceleration, deceleration injuries that occur after, associated with concussion. So even though you might have a mild concussion, you might show up days or even hours later with symptoms and signs of a stroke, which might be paralysis on one side of the body or something else. And that there are blood vessels in the back of the neck called the vertebral arteries that they can sometimes dissect and get blocked, and that could cause a stroke. A stroke is any time a blood vessel is blocked, particularly an artery. You could have a problem with blood flow to a part of the brain, and that part of the brain can die, and that's caused a stroke. Or sometimes it could be bleeding into parts of the brain, and that can cause also a stroke-like event. And that can sometimes be not so much from the arteries, which is the fresh blood coming from the heart, but could be on the other side, or the venous side, or the veins. As they get blocked, there can be a lot of back pressure and then bleeding into the brain. And there's also something called embolism, which is when a blood clot breaks off and goes into the brain and blocks an artery. Now, just quickly, just to show you a little bit of what we were talking about, you have the neurons, the main brain cell in the body, in the brain, I'm sorry. And there's a lot of input into the neurons. These are called dendrites, and they bring in signals from many other neurons, and that's how we get this neural network, or this brain network. And all these signals come into this axon, and they, by various mechanisms, tell this neuron or brain cell to either activate or not. And when it does activate, it sends a signal down one axon. Every neuron just has one axon, even though that axon can branch. And then that will then impinge upon other dendrites in another neuron. And again, this is how we propagate this very large network in the brain, with some analogies to computer systems. But just looking at one, again, you have one neuron here. The signal arrives to that neuron. It then causes this particular neuron to activate and sends a signal down the axon, which then causes a release of these little chemical packets called neurotransmitters. And they float across a little gap, and then they go to the other side, and they are attached to a receptor on the next neuron, and then that causes it to activate. This process, as I mentioned before, mediated sometimes by ions or sodium, potassium, calcium. And during an injury, a lot of these ions can go in the opposite direction, for example, and cause a lot of disruption. Calcium, in this case, potassium goes out, calcium goes in, and there's the whole network is not working as well as it should. Okay. Now let's get to second impact syndrome. Getting back to the concept of allowing the brain to heal, it's very important because there is this concept, fortunately very rare, but there is this phenomenon called the second impact syndrome. And this is during a phase where after the brain has been concussed, it hasn't fully recovered, and it's much more susceptible to re-injury, whereas a very minor force can lead to a second concussion, and in some cases can lead to a sudden and severe swelling of the brain, what they call second impact syndrome. And that can occur minutes, hours, days, or weeks after the initial injury, depending if you've recovered or not from your initial injury. And it could be, again, from a relatively minor impact, but it could cause catastrophic increased pressure within the head and increased swelling of the brain, and it often is fatal. Fortunately pretty rare, but often it occurs in individuals who sort of neglected that they had a concussion, just sort of downplaying their symptoms, or they were sent back to play a little bit too early before they had fully time to recover. And it is a phenomenon seen mostly in younger individuals, in younger athletes. Also a function because more individuals of that age are playing sports. So in this situation, there's a very severe sort of energy crisis, and after concussion, the brain cells are very, very susceptible to another injury. So you really have to allow it to have time to recover. Now, there are ways to sort of measure and look at the metabolic activity of the brain, and one is through what's called a PET scan. And this interesting study showed that even in mild head injury, or what would be called a concussion, you could have issues within the brain on a biological basis that are sometimes similar to what you see in severe head injury. So here you see a relatively normal PET scan and a Glasgow Coma scale of 15, in other words, somebody fully awake and normal. Here, someone with the same level of consciousness and the same ability to engage after a mild concussion or a mild head injury, and then somebody with a severe head injury who is somewhat comatose. And you can see that the metabolic activity of the brains, though it's a little bit worse in the severely comatose individual, there's still pretty significant metabolic disturbance within the brain of the concussed individual. So just because somebody has had a concussion and then you can talk to them and they're engageable and the symptoms go away quickly doesn't necessarily mean that they can jump right back into play, because there can still be trouble underfoot, and this concept of asymptomatology or lack of symptoms in concussion or after concussion, you still have to be much more meticulous and methodical about deciding when somebody's fully recovered from their event. So what happens after brain injury, or in particularly, and we're talking mostly about concussion, but also other forms of traumatic brain injury that can occur in sports. Seizures and epilepsy can occur. Anything that affects brain metabolic activity or causes any structural change to the brain can definitely lead to seizure events. These seizure events might be overt. You might actually see a seizure, But sometimes there could be electrical disturbances of the brain that are subclinical, that you don't have an observable seizure event, even though there's electrical disturbances of the brain that might be causing significant problems, neuropsychological changes, memory problems, concentration and learning, etc. Headaches is quite common after concussions as an event post-concussion. Various forms of dizziness, lightheadedness, vertigo, which is a rotational sensation, ringing in the ears, memory impairment, various forms of behavioral changes of all types after concussion, sleep disruption and sleep disorders, visual problems are very common after brain injury, light sensitivity, sound sensitivity, movement, uncontrollable movements, balance issues mentioned before, incoordination, and loss of sense or smell. Particularly, I showed you before a picture of the bottom of the skull and the bottom of the brain. There's two little areas in the bottom of the brain that control smell, and they could be damaged from impacting against the bottom of the skull. And if you lose your sense of smell, that also impairs your sense of taste. Fatigue and tiredness, and a decreased tolerance for alcohol and drug use. Nobody's advocating alcohol and drug use in general, but of course it does occur, and particularly individuals that might be involved in sports might have some tendency for this, and after recurrent concussions have even less tolerance for using recreational alcohol and or drugs, and or prescribed drugs for that matter. The various cognitive issues after concussion are listed here: attention, concentration, rate of processing, communication, organization, memory, problem solving, abstract thinking, simultaneous processing, and overall executive function, which is goal setting, self-monitoring, initiation, and planning. Now, of course, when this occurs, and if we're talking about individuals that are engaged in a school setting or a vocational program, or have jobs, this can impair functioning in all those different settings and need to be addressed. This is what reading could look like after a concussion of various forms, and some of this is amenable to interventions and treatment, various forms of vision therapy post brain injury. But this is what can occur, and again, people might not necessarily admit to it, and they'll just suffer along, and their academic performance will deteriorate. People have heard of the post-concussive syndrome. It's listed as a psychiatric disorder in the Diagnostic and Statistical Manual, or DSM-5, but it's not a psychiatric disorder. It's a true neurological disorder. It's defined by persistent symptoms that are persistent for over 30 days after the concussive event, and they include things like headache, depression, neuropsychological effects or deficits or impairments. And people that have post-concussion syndromes, what it's telling you is that the brain hasn't fully recovered, and in that situation they are susceptible to repeat concussions. And every time you have another concussion on top of a previous concussion that hasn't fully healed and hasn't fully recovered, you're setting yourself up for very long-term sequelae, and for some instances, unfortunately, there are people that have persistent and even permanent post-concussive states. And you've probably heard about some of the professional athletes that have gone around the country who are now in retirement and suffering from post-concussive syndromes like daily headaches and various emotional and behavioral changes. And it's a very sad situation, but it was somewhat preventable. But these are individuals that were often either encouraged or even forced in some situations to return to sport activity before they fully recovered from their concussions, and there was just one on top of the other on top of another, and led to a repetitive injury. And again, the other issue we talked about is second impact syndrome. And again, if post-concussive syndrome is telling you that the brain has not fully recovered from the initial concussive event, then it's also telling you that it's susceptible to second impact syndrome. So somebody with a post-concussive syndrome should be considered as still in a post-concussive state and not fully recovered from their concussion, and have to be treated as such. Now, after a mild traumatic brain injury, and again, mild really should be in quotation marks, there can be long-term effects, particularly if there's repetitive events. And we talked a lot about this, again, the concept of allowing enough time and also to actually measure it that somebody has fully recovered. And there's many, many different reasons that this occurs on a pathological basis. There's changes in the structure of the brain and the structure of the brain skeleton, if you will. And there's various proteins that can be sometimes produced that can be very toxic to long-term brain, and leads to sort of a dementia type of process. And this has commonly been described over the years in professional boxers. Not surprising in a sense, since boxing does include the intent to try to inflict a brain injury on your opponent. And in the old days, if you will, I mean, people were boxing, having boxing matches every week or two. And that repetitive brain injury led to deterioration of the brain, both structurally as well as functionally. But now it's recognized that there's this entity of chronic traumatic encephalopathy. I'll talk about that in a second. And there can be even a form of Parkinson's disease that occurs after repetitive brain injury. The risk of chronic traumatic encephalopathy, which probably would include the Parkinsonianism, is about 17% in boxers, at least those that have been studied. And also individuals in collision sports seem to be at the highest risk for this very chronic deterioration of brain function. And everyone is aware of Muhammad Ali, who in his prime was the greatest boxer of all time, but also then developed a strategy of what they called rope-a-dope, where he would hang out on the sides of the ring and just absorb as many punches as he can to wear out his opponent, and then would go on the attack. And I think that, plus just participating in some very high-level boxing events, led to a lot of repetitive head trauma and thus brain trauma. And he now suffers from Parkinson's disease, which more than likely was not something that would have happened to him, but is more than likely from his participation in boxing. And chronic traumatic encephalopathy, again, usually from repetitive brain injury, it could be repetitive concussions in particular, leads to memory disturbances, behavioral and personality changes, Parkinson-like disease, speech abnormalities, problems walking. And when you look at the brain, there's a distinct pathology. This has also been described in football players who have gone to autopsy after suicides, where they've donated their brain. And you can see a very distinct pathology in the brain, which is really a deterioration of the structure of the brain. So in assessing concussion, it's important to recognize concussion, identify it, because you want to avoid additional brain injury. So there should be, in the issues of sports, there should be trained and certified on-the-field personnel, and there should be they should be trained in performing sideline assessments. If somebody has a concussion identified, they need to be removed from play. That's just there shouldn't be any doubt about it. There was, I think it was recently in the World Cup preliminaries where somebody was knocked out on the field and then went right back in, and nobody pulled him out. And he was obviously had impaired or loss of consciousness even briefly. That by definition is a concussion, and someone like that should not be allowed to play, at least for that game. And then by accurately identifying a concussion, you could allow somebody to receive the interventions that are necessary. And you could also prevent a cycle of failure by identifying those who really need various interventions and treatments for their, again, what is a brain injury. In some cases, there are certain types of pre-existing behaviors that may predispose to risky behaviors that then lead to concussion. And if so, again, if you identify the concussion, you can then also address these risky behaviors. You can't always rely on someone to report a concussion, so that's why it's important to do objective testing. In this study here, high school athletes, 50% of those who eventually were diagnosed with a concussion didn't really report it. Either they don't recognize it, they don't think it's bad enough to report, maybe they don't want to be labeled as having a concussion and maybe kept out of sporting events, so they might want to hide it. So it's very, very prone to error when we rely on self-reporting and/or symptom scales. So there should be, when a concussion is identified, a very good neurological and medical examination and evaluation. This includes an interview that will address the symptoms and signs of concussion, try to find some details about the event itself to try to determine how the force occurred, looking for any problems with vestibular or balance issues or ocular complaints, visual complaints, assessing for other forms of neurological sequelae that occurred, like we mentioned before. As part of the evaluation, there might be some neurophysiological testing or brainwave testing, and in some cases actually maybe taking a picture of the brain or a neuroimage, particularly a magnetic resonance image. And then again, an overall assessment for any kind of physical examination or neurological abnormalities. And the neuropsychological assessment is also very important when it comes to assessing somebody who's had a concussion. People have heard of the impact test. This has been popularized also in the press because when you hear about professional athletes who've had a concussion, they say they've taken their concussion test and they're ready to go back to play. Usually they're referring to an impact test, which is a little computerized assessment. It has a symptom scale on it. It has some neuropsychological measures that are very brief and compact. And it does provide some quantitative outcome. It has been studied. It is a useful tool, but again, it's not the only tool. And it is just a tool. So it's not a substitute for a really complete neurological, medical, neuropsychological evaluation. And it's not a treatment. It can measure a response to interventions, but in and of itself is not a treatment. So you have to remember that it's a tool. It provides some objective information, but as a standalone test, you could really be fooled. So you've got to be a little bit careful about that. I mentioned sometimes neurophysiological assessments are good. Here we use the dense array electroencephalogram, which is again a brainwave test. It uses 128 electrodes, very easy to place on, and it can give very important data concerning brainwave function, abnormal brain discharges, organization of brain function. It could also map out any type of abnormalities onto the brain itself. This is an MRI. And then another neurophysiological test that sometimes could be useful is called an event-related potential or an active task, EEG, where you could provide someone with a visual or auditory stimulus and then sort of measure, if you will, how fast they process it. In the first half a second or 500 milliseconds after we see or hear something, it takes about a half a second for us to respond or decide what we want to do with that stimulus. And so the event-related potentials sort of assess that first 500 milliseconds. A lot of other tools, like the impact, for example, will measure from a half a second onward. They'll measure the result of our action. So this is sort of the prequel, where those are more of the sequel, if you will. But it's a measure of a neurophysiological measure of processing. And you can see here, this is just a map of a certain signal that came in and where it goes in the different time frames. And there's different things we can do and measure in determining whether the brain is differentiating properly or not. This is an MRI machine. Sometimes it'll take a picture of the brain to look for any structural changes in the brain. You can see that here as well. Functional MRI is more of a blood flow study, and it uses the MRI machine. An MRS, or magnetic resonance spectroscopy, is a metabolic measure. A SPECT scan is another blood flow measure. These are some of the things you might have heard, and sometimes these all could be useful in the post-analysis and measurement of brain function. PET scanning, which is again another metabolic evaluation. So the treatment after a concussion, there's acute interventions at the scene, depending on the level of the problem. Again, the concept that the brain needs time to heal, and the majority of concussions will heal if they're properly measured, but rest is very critical. Time and rest is very critical when it comes to management of a concussion. And so during this time of rest, really have to restrict physical activity and cognitive exertion. You could do mild activity as tolerated as long as it doesn't produce symptoms. Once there's symptoms, you have to sort of take a step back. This concept of cognitive rest is a little bit controversial, but it includes basically avoidance of a lot of activities that will stress the brain. So that would include a lot of our electronics, brain, TV, cell phone use, texting, etc. During the resting phase or the treatment phase, good sleep hygiene, if you will, good sleep patterns, being well hydrated, getting good nutrition, and really making sure that you're not in a situation where the head will be contacted again. Because I've seen a lot of individuals during the recovery phase of a concussion have some silly event that occurs. They're just outside and somebody throws a ball and they get hit in the head. And remember, during this recovery phase, the brain is very susceptible to another concussion because it hasn't fully recovered. And then after that, there's a gradual and graded reintroduction of exertion once somebody no longer has post-concussive symptoms. And then as far as sports are concerned, there's individualized decisions concerning when somebody can return to play. And this graduated introduction of exertion is really first aerobic and then anaerobic. So the initial rest period really should be a minimum of 72 hours, during which time you're really avoiding any kind of exercise or physical exertion. You're limiting any intensive academic work or intensive visual focus, such as we mentioned before. And really, it really has to be individualized because everybody's a little bit different, but anything that exacerbates symptoms or puts somebody at risk for impacting the head really has to be limited or totally avoided. Again, sleep has to be really well regulated during the recovery phase. In some cases, sleep can be very disrupted, and there might be use of pharmacological agents to help that along. And again, that would be just a temporary issue until full recovery. There are forms of what are called vestibular therapy that you'll see. You'll see that out there, and they can be somewhat controversial. Some people find them useful, and they're usually various types of practitioners will purport to have vestibular therapy inputs, particularly physical therapists. In terms of treating the late effects after a concussion, there are various forms of interventions that can be done that are non-pharmacological. These include cognitive rehabilitation, cognitive remediation approaches, educational approaches, behavioral approaches, and various forms of physical, occupational, speech and language therapies, family support, cognitive behavioral therapy, and vision therapy. In some cases, medications can be useful if there are specific issues, but again, the use of medications has to be used very carefully and judiciously, and really should be used to augment non-pharmacological approaches. And just to mention that in New Jersey, under the Special Education Code, there is a category of traumatic brain injury, and again, concussion is a traumatic brain injury, so people who have had concussions and have post-concussive sequelae are eligible for accommodations and interventions in the academic environment, and this is sometimes overlooked. And there could be a whole realm of interventions that can be done and individualized for somebody who has had a concussion as having problems afterwards. And this is all listed here. And if you go to the Brain Injury Association of New Jersey, they have extensive listings of what can be done. So various forms of academic support during recovery. It might be excusing somebody from class, particularly to allow them to rest. When they come back, you might only bring them back part of a day rather than a full day. You might let them miss their early classes so they could sleep in a little bit more, particularly if they're having sleep problems. And you might allow accommodations to allow them to leave the classroom to go to the nurse's office to rest when they have a flare-up of their symptoms. Extension of assignment deadlines, staggering of tests, excusing from specific assignments that might exacerbate their problems. And similar for accommodations that might be given to someone with attentional problems, use of smaller and quieter exam rooms, preferential classroom seating, and the use of tutors as necessary. You can see that in New Jersey alone, 16,000 total children hospitalized with a TBI diagnosis. Only 1,200 are getting special education services. So there is a big gap, and it's not quite clear. There should be about 10,000 students getting services, and there's only about 1,200 based upon statistics. And it may be that parents are fearful of having their children categorized and classified. It may be that it's not recognized that they're having latent effects from a brain injury. It may look like, ADHD or some other diagnosis when really it's a post-traumatic problem, even months to years later. And again, it's just an overall problem with under-identification and misidentification within the educational system. But there's a lot more individuals that need to be identified and receiving appropriate accommodations. So brain injury recovery, it could occur minutes, hours, days, weeks, months, years. Questions of when to return to school, work, driving, and particularly for sports. The natural history of concussions is somewhat favorable in general. In this one study that most individuals, 80%, got better within 3 weeks, but there was still 20% that took longer than 3 weeks to recover. And there are various risk factors and moderators to this. The age, younger individuals tend to have a more protracted recovery. People who have a migraine history tend to have a problem, and particularly if they develop post-traumatic migraines, they have a more protracted recovery. If there's vestibular symptoms such as balance or dizziness, that could lead to a longer recovery phase. Females seem to be at higher risk for longer recovery. If you have a previous concussion or poor management of previous concussion, that leads to a longer recovery phase. It's questionable whether if a pre-existing learning disability leads to a longer recovery phase, but so that's not quite clear, but that's been mentioned in a number of studies. And if you have persistent symptoms of 3 days or longer, that tends to speak for something that's going to take a little bit longer to recover. So just to wrap up a little bit on the one to bring an athlete back into the playing field, you need to use a graduated approach to return to play. First, I mentioned, there was this consensus guidelines from Zurich in 2008 that are mentioned here. First is to keep somebody out of play for at least, it says here 24 hours, but most people feel now 72 hours is a better window. And again, the younger the athlete, the more conservative treatment. And if they become without symptoms after 72 hours, again, if they have symptoms, you have to always go back to the previous step. Then you can start a light aerobic exercise regimen and see if that exacerbates symptoms. And then if that doesn't exacerbate symptoms, you can then go on to step 3, which is more moderate exercise. And again, going back to the previous step if symptoms are being exacerbated by this increase in exertion. Eventually going to get back to non-contact drills and exercise, more intensity but without contact. And if you still remain asymptomatic, then you can resume full contact practice, and if you're still asymptomatic, then return to play. But again, monitoring the whole time for symptoms so that you might have to go back to the previous step. How many concussions is enough? Again, the more you have, the worse it can be, and the higher risk it is for very long-term effects of concussions such as chronic traumatic encephalopathy. And this has been shown time and time again. And again, sometimes the concussion itself is not an issue. They did a recent study that you might have seen on the press about 2 months ago that came out that showed that they took 50 college football players. Half of them had a concussion and the other half never had a reported concussion. And they did MRIs and they measured the hippocampus, which is part of the brain, and they all had, or the majority had, a smaller hippocampus, and it didn't really matter if they reported concussion or not. It was pretty much the same across the two groups. So just participating in college football put individuals at risk for a smaller hippocampus long term. It was still about 20–25%, but still it was pretty significant. So it's not always, you don't always recognize a concussion, and it may be that it was just the stress of playing football that led to this event, or it may be that there was unrecognized hits to the concussions, or just the hits to the head itself is not good for the brain. But red flags, if you will, is if you start getting concussed very easily with minimal trauma, it's time to eliminate that sport and really start to protect your head. If your symptoms are increasing in severity over time, or if there's significant change from your baseline, if you will, from an emotional or psychiatric standpoint, or other functioning like motor functioning or neuropsychological functioning, if you measure it, which is important, whether it be on a computerized assessment or more formal neuropsychological testing, it's really time to decide, enough is enough. And just lastly, prevention. Of course, prevention is really the best strategy. There are protective equipment, such as a bicycle helmet, which can really help, but not eliminate the risk of concussion and brain injury. But it's also important for coaches to be trained in teaching specific skills and safe practices and proper techniques, and that can reduce injury overall, particularly head injury. Adhering to rules of play and good sportsmanship with strict officiating. There's elimination of head-to-head, or I should say head-to-head contact is being made more illegal in professional football, for example, but it still occurs, and so this still hasn't been eliminated. Strength and conditioning, of course, a better conditioned athlete, a stronger athlete might be able to withstand, particularly with a strong neck, the forces that could lead to concussion. And again, recognition and responding appropriately and intervening when there is a traumatic brain injury. So, again, playing without a helmet, it may not be a good idea if everybody else has a helmet, but if nobody had a helmet, maybe there'd be less head injury because people wouldn't want to use their head as much as a weapon. Wearing your seatbelt is a simple preventative measure. So there are some unresolved issues when it comes to concussion. It's not always clear exactly why and how long it does take for a concussion to resolve. Really, there's a number of factors that play a role in that. What age do we allow children to be involved in high-velocity collision sports? I would say these very, very young football players are probably not at a very high risk because they can't generate enough velocity. But at what age does it occur? When it comes to soccer, you know, young 5-year-olds are probably not going to get concussions from heading the ball. They're not allowed to head the ball. But at what age do we allow them to start heading the ball? Because at what age does the size of the individuals that play the sport cause a significant velocity of the ball that could lead to concussive-like events? How to best prevent concussion. Equipment, again, is a lot of focus on it, but it's not really going to be the answer. Rules, legislation. There's a lot of legislation in many states concerning traumatic brain injury, education. Resting, how long, what type of rest. You know, some people have advocated things like light therapy. It really hasn't been proven. There's no evidence for it. Supplements of various types. There's not a lot of evidence for it. Identification of the asymptomatic state, as we mentioned before. The issue of, does a concussion specialist help you? Who should be evaluating the concussions on the field and evaluating them afterwards? Is there anything such thing as a safe sport? You know, in soccer, there's evidence of cognitive decline in elite soccer players that's associated with the number of times they head the ball. And these are individuals who haven't reported concussions. And what constitutes a true concussion test? If you have a lot of information, if you need more information on concussion and in terms of prevention and identification, there's a lot of important sites for that, as I list here. Centers for Disease Control has a lot of information on concussion. Brain Steps is a good resource for concussion. Brain Injury Association of Jersey as well. The Impact Resource Center is where the impact test is housed, if you will, but they also have information on concussion in general. And the American Academy of Neurology has a very good toolkit for what to do for sports concussion. So I want to thank you. Concussions are a traumatic brain injury. They are common. It's a complex structural and biochemical injury. The outcomes are variable. Mild injuries can become severe if they're not recognized or managed properly. Severe injuries can become mild if they're properly managed. Treatment is multifactorial. There's no one way to treat a concussion. It has to be managed very, very clinically, and prevention strategies are vital. Thank you.
All right, Dr. Mintz, thank you. We've gone a little long, and I am going to have a number of questions, and I want to try and get to some of them, okay? So
Sure.
Hopefully people will stay on the line and be able to, hear some of the questions get answered. This question is from a school nurse, and basically she's asking that the general pediatrician seems to be reluctant to put in place any concussion protocols, and that as this nurse, she often sends suggestions and protocols to the parent to take to the doctor, and yet the doctor doesn't seem to be following through with that. Would you talk about that a little bit?
Well, I would just, again, point out the resources that are available, American Academy of Neurology, the Brain Injury Association of New Jersey. There are very good defined approaches to concussion, and, I would just emphasize to the family that this is what's out there, and actually direct the families to these resources. And then, if the pediatrician is not responsive to the school nurse's suggestions, maybe the family then has to intervene, if you will, and educate the pediatrician about these protocols for concussion that are already out there and accepted. So
you're saying that if the family parents in this case then should be more proactive in getting the kind of information or getting the doctor to follow through on the things that the nurse is suggesting.
Yes.
Okay. Is there any kind of ballpark or criteria or anything that you could say that after how many concussions should athletes not participate in sports? Is there, I understand that the severity of the concussion, but is there any guidance along those lines?
Well, the guy, as I would say, is that it really has to be individualized, and in such a situation and for such a decision, I've been in that situation many times, and it really has to be individualized. So there's a lot of factors that play into that. The number of concussions is part of it, but it's also the type of concussions, how well they recovered, um, is there any long-lasting sequelae, and then getting as much objective information to make that decision. So during neuropsychological testing, neurological evaluations, neurophysiological testing, I mean, if all that is normal and hasn't changed, if you will, over time, and there's no symptoms, then the number of concussions might not be as relevant as other factors. So you might have 2 concussions and have a major decline in neuropsychological function is much more important than having 5 concussions where nothing has changed and everything is normal. So it really has to be individualized. So it's not just the number of concussions. There's a lot of other factors that play into that decision. And it's an important decision, particularly if people are at high levels of sports, either at collegiate level or and particularly at a professional level, to make a decision to walk away from the sport where you're making your living is a major decision and shouldn't be taken lightly.
Okay, thank you. How do you differentiate neurological symptoms that are due to concussion and neurological signs that existed in the patient before the event? So most doctors who might be diagnosing the concussion have not seen the student before the incident.
Yeah, so again, that can be very problematic, and it could lead to misidentification as well as misdiagnosis both ways. I mean, you could attribute things to a concussion that probably are not from the concussion and vice versa. You can miss a concussion symptoms because you're attributing it to pre-existing issues. So if you have reasonable information and data, from before the concussion, obviously now you have a comparative base. Unfortunately, so the testing that you do after the concussion can be compared to before the concussion, and you can see if there's a major change, and then you can see what you could attribute to concussion or not. On the other hand, what often is the case, and the thing that I see most often is that we evaluate individuals for the first time after the injury, so we're getting a post-injury baseline. Then we could use that baseline to look for recovery. And if there's recovery, then we can start saying that what we were looking at was from the concussion. If there's no change, then it's still a little bit unclear if these are pre-existing issues or from the concussion. But you should, since most concussions you'll have some recovery, if you have a post-injury baseline, and then give it some more time, if you will, and then a reevaluation at some point, and you're seeing recovery, then you're dealing more with a concussion issue, where if there's really no change. And you don't have any pre-existing information, it's probably from a pre-existing phenomenon.
Okay. Since we're the Tourette organization, I have a question here about Tourette. Can a severe tic re-injure the brain after concussion? The tic involved is flailing the head back and forth violently.
Yes. I mean, if it's really severe enough, as long as you have these forces imparted upon the brain, if there's a violent movement of the head one way to the other, and sufficient to move the brain in a certain direction, those forces on the brain in a recovery phase after concussion, could potentially lead to either a more prolonged recovery or could also cause re-injury in some cases. But I would say it's probably unusual. Because the amount of space, if you will, that the tic occurs in, the movement of the head is sort of fixed, whereas the acceleration, deceleration of concussion are usually occurring in a larger three-dimensional space where somebody is running and gets hit or something along those lines. So starting from 0, if you will, then going to 60 miles an hour, if you will, is probably not as in one fixed area is probably not going to cause any major problems.
Okay. I have a question from a medical professional. So you can decide whether this is an appropriate forum to answer this, okay? But what are effective treatments for post-concussive headaches?
Yeah, it's almost a lecture unto itself. And it, again, has to be individualized. I think the first issue is going to be the evaluation to try to see the source of the headaches, because the headaches might have identifiable sources and causes that might be treated in terms of their mechanism rather than just as their symptom of a headache. If there's no identifiable cause or source of the headache and it just appears to be a post-concussive symptom, again, it depends on the age of the patient, the type of patient, the recovery phase, and like all headaches, it'll be treated somewhat with an approach to either symptomatic therapy, trying to reduce the pain, versus prophylactic therapy, trying to reduce the frequency and severity and intensity of the headaches. Post-traumatic headaches sometimes appear to, since it is a biochemical phenomena, as opposed to just headaches in general and migraine, sometimes they could respond to magnesium supplementation, something simple. But some of them do require prophylactic therapy. Some medications that are used for prophylaxis are things like Topamax, some of the seizure medicines. One is called Topamax, and some of the anxiety agents, antidepressants, one is called amitriptyline or Elavil. They could be useful. There's others that could be as well, and there's a lot of pre-testing that needs to be done before giving these type of medications. It's not something that you would just give, and there's potential side effects from the medications as well, so you have to really look at that. And as far as the acute events, non-steroidal anti-inflammatory agents, ibuprofen, naproxen, etc., for just the pain. But of course, in all headaches that are lingering, and including headaches after concussion, you want to be very, very careful and probably avoid altogether narcotic-like medications and or the chronic use of pain medications. Chronic daily use of pain medications actually can worsen headaches because it causes a phenomena of rebound headaches and actually can make things a lot worse. And narcotics, of course, can lower your pain threshold. You become more dependent upon the narcotics, and in some situations you can even become addicted. So it's really an approach of trying to figure out the cause of the headaches, see if there's an identifiable treatment in that sense that's not just symptomatic, and then on the other hand, then treating the symptoms and prophylaxing against the headaches themselves.
Okay, thank you. And I'm going to have one last question here because I think it's a really good one to stick in here at the end. Is it best practice to replace a helmet after a concussion?
I'm not sure the question. What do you mean by replace the helmet with a different
Well,
one?
let's say I'm assuming this is maybe a football helmet. So someone wore a helmet, had a concussion, and so would it be wise then to replace the helmet?
I would say it depends on the nature of the concussion. If it was a head-to-head helmet blow, then yes, then the helmet might have been damaged. But if it's just an event where the helmet wasn't involved, such as just from a body collision that was just severe force, maybe a very strong tackle to the body that just caused a severe movement of the head, then it's just I don't know, then it'd be somewhat optional. But again, the helmets themselves don't really prevent concussions so much, as much as they do protect the face and the skin, if you will, and maybe prevent somewhat fractures of the skull. But the movement of the brain, the acceleration, deceleration force, and the rotational force of the brain is not really reduced by helmets. So it's not so much the helmet, it's really the nature of the force.
Okay, Doctor, I think we're going to wrap it up here. Thank you very much. A lot of great information, and the questions that we didn't get to tonight we'll include on the blog. So
Okay.
Thank you, everyone, for joining us. I am going to sign off and turn this over to Kelly.
Thank you for joining us on our webinar on sports-related concussions and brain injury. There is an exit survey which we need everyone attending to fill out. The webinar blog is open now and available for the next 7 days on the NJCTS website for any additional questions that were not covered in tonight's presentation. That website is www.njcts.org. Also, an archived recording of tonight's webinar will be posted to our website shortly. This ends tonight's webinar. Thank you, Dr. Mintz, for your presentation and time, and thank you, everyone, for attending.